Hello, everyone. Thank you so much for tuning in today for our OrthoVirginia Facebook Live. My name is Ryan Robertson. I'm one of our joint replacement doctors here at OrthoVirginia. And our topic today that we're going to be covering is how to stay active with arthritis. Obviously, as a joint replacement doctor, I have a lot of patients who come in to see me in varying different stages of their lives with varying different stages of arthritis. And so we thought this would be a good topic to cover today, going through sort of all the different aspects of arthritis, as well as then what do you do to treat arthritis? How do you stay active? What is the role of staying active? Are there medications we can do to try to help with this? And then obviously being a joint replacement doctor, where does surgery work into this? And can you still be active after surgery and sort of going against some of the grain of people viewing that surgery means you can't be active anymore and you can't do things, and actually freeing you to believe that surgery actually can be the gateway to keeping you active, keeping that quality of life that you want, and allowing you to stay an active lifestyle that allows for better longevity. So obviously, arthritis affects all of us. So 91 million Americans are affected by the different forms of arthritis, the majority being osteoarthritis. And then specifically just thinking about it from a knee standpoint, something I deal with a lot, 45% of people have a lifetime risk of developing some degree of symptomatic knee arthritis. So what makes up arthritis? Common question I get is, why did I get this? Was this related to a family member that I had, or was it my high school football? And it's everything. So everything plays into it. It's multifactorial, a little bit of how your anatomy is, maybe some trauma you had as a child, overuse things, genetics. So yes, your family does play a role in it. It very commonly will run in families. And it is something that does get worse over time. So normal joints, normal healthy body, it's kind of like a well-oiled hinge. It's got healthy cartilage, it's lubricated, you've got good motion, and it doesn't have any pain. However, a arthritic joint is much more like a rusted hinge. It's damaged. The cartilage has tears in it. You may be referred to as having bone on bone, and you start losing motion. And then obviously with that motion, you have pain. So what does that look like? What does that present like? So this is what a normal x-ray of a hip would look like. It has good joint space. It doesn't have a bunch of cysts. It doesn't have a bunch of bone spurs, versus an arthritic x-ray looks more like that rusty hinge we talked about, where you've lost that nice round circle. You're getting a blunted, rounded, mushroom-shaped circle. You're getting bone cysts, which are those little circles that are in the bone, in the ball. You get that white, dense, sclerotic bone that shows that it's been angry, shown that it's been damaged. And that's sort of the radiographic findings of arthritis. And the same thing happens in the knee. You have a normal knee, good joint spaces, smooth surfaces, no bone spurs, versus an arthritic knee, which is much more like a rusty hinge, where it's starting to get that narrowing, it's getting that sclerosis, getting those bone spurs, and you also start getting more deformity in knees. So you'll get a bowing out of the leg or a bowing in of the leg. So you get knock knee, or you get bowing of it, and you get that thickening of the knee. The knee gets swollen and gets larger from the bone spurs or from the swelling with it. And obviously there's a spectrum. So just because somebody says you have arthritis, there's different things. And a lot of people use the word bone on bone or end stage, but all of these stages have pain. And so what can we do along those stages to try to keep you from developing, end stage where you need arthritis, or where you've developed symptoms enough to where you need to have surgery for it? Obviously, arthritis is a disease of the cartilage. So obviously, there's lots of parts that go into the cartilage with the different substrates. And we'll talk a little bit about some of the supplements people talk about, and does that help with the cartilage. But most of these things are about functionality and keeping your quality of life up. So the multiple steps that go into it, it's integrative. There's lots of things that go into the health and management of arthritis, not all provided by an orthopedic doctor. We act as some of the sort of gateway for some of these, but otherwise there's lots of different aspects between exercise and manipulative therapies, cognitive therapies, doing lifestyle modifications, nutrition, and sometimes when Western medicine, like formal orthopedic care, fails to give you adequate relief, sometimes looking for some of the Eastern medicines and things can be an option to help with everything. So why do we want to stay active? Why are we talking about this today? So obviously, exercise reduces fatigue. Exercise also helps with a lot of metabolic and medical diseases out there. Diabetes helps control your sugars. Heart disease keeps your blood pressure down, keeps the blood circulating well in your body, keeps your heart strong to avoid cardiovascular disease as we age. And it actually has been shown to help with both the avoidance of cancer and then those people who then do develop cancer to help cure cancer and treat cancer. Also has been shown to help activate your immune system so you're less likely to develop respiratory diseases and other autoimmune diseases. It helps with tension and emotional states. It helps with depression. It helps with relaxation so that we have better overall quality of life, things that we want out of our day-to-day lives. And then obviously, exercise is what we need to keep up our muscle strength, maintain mobility, decrease falls, and overall lead to a better quality of life as we age. And overall actually can help just live longer. They've done good studies showing that those who exercise have a longer longevity in this world. And so we want to keep you in that lifestyle. So what does it mean, exercise and aging? Well, unfortunately, as we age, we tend to be less active. Well, unfortunately, if we're less active, we're going to have deterioration in our muscle strength. And that can happen at a rate of 3 to 5% every decade after age 30. So it is pretty rapid as we age if we do not stay active. And obviously, if we don't stay active, we lose strength. If we lose strength, we have decreased balance. It impacts our activities of daily living. So we're doing less, we're able to do less on our own. So we need more help from other people or from devices or from other sources. And obviously, for me as an orthopedic doctor, I do a lot of hip and knee replacements, but I also do a lot of orthopedic trauma call, and I take care of a lot of people who fall and break joints and break bones. And obviously, we want to avoid that for you. So staying active helps avoid those falls and avoid those injuries. And obviously, as we get weaker, then our ability to do things goes down. And as our ability to do things goes down, we exercise less, and it becomes a downward spiral that leads to a worse quality of life. So what does that mean? How can we stay active, whatnot? So sometimes you can't do everything you could do 10, 15, 20 years ago because your joints hurt or you're weaker or things. So we have to look at how do we modify our activities to allow us to stay active and to keep impacting our physical state and to get better. So sometimes doing lower impact activities like in this image with biking or getting in the pool, doing water aerobics, use that water to counteract some of the weight on our joints to help with it. Doing that activity will decrease some of our arthritic symptoms as well. There's good data that shows that activity will actually treat the arthritis. So it's a double-edged sword that obviously activity hurts our joints and makes them hurt more, but actually doing the activity will decrease some of the pain. There's anywhere, if they've done a good study recently that was in the American Family Medicine Journal showing that if you exercise for 20 to 30 minutes, 2 to 3 times a week, there's a 30 to 40% decreased risk of needing surgical intervention on your joints. Otherwise, if you can't do an actual impact or weight-bearing exercise, you can still get benefit from doing movement therapy like yoga or Tai Chi. Helps bring blood flow to your joints, helps encourage muscle strength and isometrics to help stabilize those joints and can decrease your arthritis. As we talked about a little bit earlier, I'm not an expert in this, so I can't speak very well to this for anyone who has questions about it, but there is value in alternative therapies. So acupuncture, manipulative therapies, cognitive therapies, and definitely are something to pursue and look into to help you in your joint pain. Obviously, a common question people ask about is about weight loss and are my joints wearing out because of my weight? Not isolated, not just because you weight, but it is something that plays into that multifactorial. So yes, your hips and your knees see 4 to 6 times your body weight every time you take a step, especially doing stairs, especially getting out of a chair. And so any weight you do lose takes stress off your joints, helps with pain, helps decrease the wear out of your joints over time. And then obviously, yes, if we have to do surgery in the future, may make you a safer candidate for surgery in the future. So then after that, next step commonly we talk about is medicines. So The biggest gold standard medicine is anti-inflammatories. There's lots of different versions out there between those over the counter, those prescribed by a provider, as well as then some of the anti-inflammatories that we'll get into a little bit later that are nutritional anti-inflammatories. But something you want to talk to your medical doctor, talk to your orthopedic doctor. Obviously, it involves your medical doctor because some of these medicines are contraindicated for some medical diseases. And so you have to work with your doctor on these things. Next step is injections. Commonly question that's asked to me. There was recently an article in the AARP about injections. They are variable about how much relief they provide people, but sometimes an injection can keep you moving. It helps manage your pain, that allows you to stay active so you avoid that initial hindrance and barrier to exercise, and gets you all those secondary benefits of exercise and staying active. So the first one, most common used one, steroid injections. They're an anti-inflammatory injection. You can get 3 to 4 of them a year, and it does have benefit to help with function. Now, yes, there is some concern about the effects of them on your cartilage long-term, and yes, it does have long-term effects on the cartilage, but we're trying to keep you active with an arthritic joint already, so we're already dealing with a compromised joint. And yes, eventually they will have less effects, and that's where we have to then choose other modalities to try to help it, or possibly in the future move towards surgical intervention. The other 2 common injections are lubricating injections or hyaluronic acid injections, as well as stem cell injections, PRP injections. Both have variable effects for different patients. Both are geared at decreasing inflammation. None of these injections regrow cartilage, reverse arthritis, or prevent you from having future issues down the road. They're to help your symptoms at the moment. Next thing is we sort of talk about are the supplements. There's a lot of supplements out there. There's everything from glucosamine chondroitin sulfate, which is the most common one talked about. That's that material that's in the cartilage. The hope is that by creating a higher store of that in your body, you're able to heal anything with your cartilage or keep your cartilage healthy. But there's no great data that shows that it reverses arthritis or it prevents the progression of arthritis, but there's some dogma in people that believe in it. And it's low risk, low cost, no major issue. People commonly ask about diets, low inflammatory diets or anti-inflammatory diets, low carb, low glucose, those low fat, those can have some effect, but there's no great standardized answers for that. Lots of anti-inflammatory foods out there, leafy vegetables, berries, turmeric, which has curcumin in it. That all can be helpful, but I don't have any one recipe to give you to fix with all of it. And so it's another tool in our toolbox to try to help with all of this. Next slide. So surgery. When do we talk about surgery? How do we talk about surgery? It is definitely the end, treatment for helping with arthritis, but it can sometimes be that treatment that allows for us to get back that functional quality of life and to keep you going, to keep giving you that active, fulfilling lifestyle that also helps minimize some of our other medical comorbidities. So you get back to activity, it helps you lower your weight, helps to avoid diabetes, helps to keep your cardiovascular disease healthy. And so all of those aspects, I view arthritis surgery not as a limitation to your future, but hopefully a gateway to your future. We'll talk about each one of them sort of individually. So I do anterior approach total hips. I do that because I think it adds a value to my patients. You have a smaller incision in the front of the knee, front of the hip, so less soft tissue disruption. I do use robotics with the navigation and I use a table. So I think it helps minimize the soft tissue dissection, recreate bony anatomy, less trauma to the body, hopefully leads to less pain for the patient, a quicker recovery, and then also allows me to have less restrictions after surgery. That means hopefully allows you to get back to more activities. I do restrict people for the first couple of months, but after 3 to 4 months, I tell patients you're able to do anything you can tolerate. And most people can get back to doing at least their pre-surgery level of activity with less pain, but hopefully even better activity. I have patients who get back to running after hip replacements. I have some who get back to doing triathlons. I have a lot that get back to doing fairly aggressive recreational sports like pickleball or tennis or even getting back to, cross country, riding their bike and everything. So I do view it as a, treatment to help stay functional, not as a, hey, you can't do those things after my surgeries. So then partial knee replacements, that's another great one that we talk about for knee arthritis. So a lot of people know about knee replacements, know how painful knee replacements are and how big of a recovery are. Partial knee replacements, smaller surgery, less invasive, less soft tissue disruption, feels more like a native knee because we leave the other parts of the knee alone. We leave all the ligaments alone. And so it gives you that more physiologic feel to the knee that allows you to get back to doing more of those high energy sports, tennis, running, even on a partial knee replacement. But if you can't feel the tolerance of the running, at least biking and other low impact things with it all. Commonly people are, well, am I a candidate for a partial knee replacement? More people are a candidate for a partial knee replacement than actually are getting at the moment. There was a study that showed that probably 50% of patients could have a partial knee replacement, but yet in the United States, we only do about 8 to 10%. In my practice, it hovers somewhere around 20%, and I think it could be even higher. And I'm always looking for the right candidates to give them that quality of life. And so the old dogma of it's for older patients, it's only for people who have a good ACL, it's for lighter patients. I think it can be a great surgery for all comers in the right situation. And it avoids the alternative surgeries for cartilage surgeries or high tibia osteotomies that have complications, that have possible need for further surgeries down the road. In my hands, a partial knee replacement is a 20 to 30 year replacement and hopefully allows you to get back to that active lifestyle that you want. And so the last one that I do, that I still view as a surgery that can liberate people and allow them to get back to their activity, is a knee replacement. So I do robotic assisted total knee replacements. I think that allows me to do a patient specific surgery that I'm not trying to change your anatomy too much, not changing your soft tissue tension, allow you to get back. We're just trying to, in some degree, rechange the wheels, rechange the shocks, rechange the brakes in your car and get you back to function with minimal impact on it. Also allows for better use of ingrowth knee replacements, so that hopefully leads to better longevity and what feels more natural with the knee. And so I think those things will allow for return to more of a normal activity afterwards. Can I guarantee that you get back to everything you did before a knee replacement? Unfortunately, I can't. There is a common, more mechanical, robotic aspect to the knee afterwards, but we're doing everything to try to minimize that impact on you and feel more natural to allow you. And after 3 to 4 months, I give clearance for you to try anything. Doesn't mean everything will feel good, but you're cleared from the implants and my surgery to do anything you can tolerate. So the common question I get after these surgeries is, well, okay, doc, you told me it's going to last 20, 25 years. What happens after 25 years? Does it mean I'm going to fall apart and I'm going to need another surgery in my 60s, 70s, 80s? And not necessarily. After 26 years, it doesn't just fall apart. Some of them continue to function well. We talk about it's a 0.5 to 1% revision rate per year. So that means at 10 years, 90 to 95% survivorship of our implants. 20 years, it's 80 to 85% survivorship. And then even after that, it can wear out, it can loosen, but there are surgical interventions that we can do that sometimes still are minimally invasive to allow for you to continue to go on, to stay active, to stay in a good quality of life for the rest of your days. So in summary, obviously our goal as orthopedic providers, and specifically mine in my practice as a arthritis joint replacement doctors, is to keep people active for as long as possible without surgical intervention through non-operative methods, whether it be medicine, whether it be injections, whether it be therapy, braces, other things to help with it. And then as long as you stay active, that will keep your joints healthy, it'll keep your body healthy, it'll avoid other medical comorbidities that we're trying to help you through. You can use medicines, use supplements to do that, but when all those things start to fail, then we start talking about surgical intervention, not as a resolution to a change in lifestyle, but hopefully as a liberation to keep you active and keep the quality of life you want for it. Otherwise, that concludes my slides I have for today, and otherwise would open it up for questions. I know we've been having some come in through the feed while this has been going on, and so I'll let Margaret sort of lead some of the questions she's been filtering through. And please, if you have other questions, please continue to submit your questions through our feed, and I'll try to answer as many as we can. We've got another about 30 minutes to answer questions, and I hope we'll get through as many as possible.
Thank you so much, Dr. Robertson. So are knee braces while exercising good if someone has knee arthritis and wants to stay active?
Yeah, so I think knee braces, knee sleeves, some type of assistive device for the knee can be very liberating for some patients, but it's not for every patient. So with that, you're looking for, one, does it feel more supportive? Two, is it comfortable? And if not, I wouldn't just wear it for the sake of wearing it. So some people get benefits. Some people, though, do feel that the brace is constrictive and is uncomfortable and they don't like it. So in that case, then no. But there's lots of variety of braces, and obviously can talk with your provider or me about that. Sometimes just a knee sleeve, the compression around the joint does provide a degree of what we call myofascial feedback. So you feel more supported, your muscles fire better, you get some warmth out of it. So it really can help you with that. But then some people need a little bit of support mechanically. And so there are some with bracing on the sides of the joints, but then there's others that actually do corrections of the joints or help unload some of the compartments of it with other devices. And so there are even more sophisticated ones, but obviously with the increasing degree of support and correction does bring extra costs. A lot of them are covered by insurance, but some of them we have to have custom made for you and for your body.
Thank you. How do you know when it's time for a joint replacement, especially if you've been having injections and doing the anti-inflammatories, activity modification, and so on? How do you know when it's time to step up that treatment to surgery?
Yes, that's a great question. One I commonly get in my practice, and one I work through it with people. And so I tell people, if we can keep you comfortable with all the other conservative measures, and that's what we should do. We don't jump ahead to do surgery just because we know it's going to happen down the road, and just because we know you have arthritis on your x-rays. It is about quality of life. And if you have good quality of life, I can't make that better with a surgery just because we know you have arthritis. So we'll live with your good quality of life with your arthritic joint as long as we can through those modalities of injections and therapy and bracing. But once you're having impact on your quality of life, I describe it for people when you're having more bad days than good days, and you could actually look back and say, you know what, I can't keep going on with my joint the way it is. That's the right time to move forward with surgery. And the common then rebuttal question I get is, well, I hear so many people tell me they wish they'd done it sooner. And yes, we all wish we could time everything perfectly, but you'd rather be on the back end and say, I wish I'd done it earlier than, oh, I did it too soon and I wish I'd never had the joint replacement. And so I don't want you ever to feel like you're pushed into a joint replacement. That's not my goal as a joint surgeon. My goal is to give you the treatment you need at the time you need it. And whether that be conservative or surgical, that's what we're here to help you through.
Thank you. How often can the hyaluronic acid injections be repeated?
So in general, the hyaluronic acid injections can be done every 6 months, whether that's covered by your insurance or whether that's out of pocket. The stem cell injections, most people do similar type of schedule, whether it be 3 to 6 months for that. Obviously, those are straight out of pocket. No insurances cover the stem cell or the PRP injections. And then obviously, as I said earlier, the steroid injections can be done every 3 to 4 months.
Thank you. Are there exercises that you suggest doing or ones that you suggest avoiding when you have knee arthritis?
Yeah, so with knee arthritis, obviously the more bend you have in the knee, the more stresses that are going across that knee. That's where I talked about the 3 to 6 times your body weight. And so deep knee bending exercises are going to be more aggravating to the knee. Now, obviously we want to encourage motion. So some degree of motion exercises is good for it, but repetitive deep motion can be more irritating. So I a lot of times talk to people about avoiding lunges, avoiding deep squats. Another thing is open chain exercises. So in the gym, those leg extension machines, those leg curl machines, those are more aggravating on your kneecap, more aggravating on that bearing between the thigh and the shin bone, because you're forcing all of that stress and you have a long lever arm to go through that knee and can be more aggravating and cause more irritation of that symptomatic arthritis.
Thank you. So you explained several different types of treatments. Are they only for osteoarthritis, or are they also the same treatments for rheumatoid arthritis?
So all of the ones I talked about are applicable for rheumatoid arthritis as well. I talked about them in the sort of, understanding of sort of the framework of osteoarthritis, but the x-rays look slightly different. The treatment has additional treatments for rheumatoid arthritis because obviously rheumatologic arthritis also has a physiologic autoimmune component. And so you do want to work with a rheumatologist or your medical doctor to maximize medical management of that. But exercise still has a role in rheumatologic arthritis as well, and has been shown to decrease joint pain in rheumatologic arthritis. So we want to do all those other modalities as well. Injections still have a role in it. Weight loss still has a role in it. Bracing can still have a role in it. But you bring in disease modifying agents and medical management for rheumatoid arthritis that is not used in osteoarthritis.
Thank you. Are robotic knee replacements the norm now, or do the majority of surgeons still do traditional knee replacements?
So I think robotic joint replacement is a growing field inside of joint replacements. It is by no means the gold standard or even the majority of joint replacements at this point. It's sort of becoming a rising trend. More and more doctors who are coming out of training are training on it and are seeing some of the benefits that I alluded to. But there are still plenty of surgeons out there who do a very good job with traditional instrumentation. But I think, in at least in my hands, I provide a more reproducible, precise surgery with that, and also feel that it adds some extra benefits that I can't offer with a traditional instrument. I know how to do both of them. I can do both of them if push comes to shove, which is always, I think, a skill set that any surgeon who does robotics needs to be able to do traditional instrumentation, because there are issues that come up with robotics where they fail or something comes up in the surgery, and we don't want to then be limited in what we can offer and can do for patients. And you have to understand the basics of a good joint replacement with traditional instrumentation to be able to do a good joint replacement with a robotic instrumentation. So that's where you want to be going to somebody who does a high volume of these surgeries, does at least 50 joint replacements a year, so that they have proficiency in it, they have familiarity with it, and they know how to take care of issues if issues do arise, because unfortunately complications and issues do happen, and you want to go to a doctor who knows how to handle those and can take care of them.
Thank you. If someone is having a bad day and their joint is sore, is it better to rest or to push through? The person who asked has been told both, so isn't sure which way to go.
Yeah. So that's a great question, and it's not an easy one or a straightforward one, and that's why you've gotten different answers from different doctors, and that's the hard thing for us as healthcare providers is we are sometimes the barrier or limitation to patients staying active, is that they go in to see a doctor and they complain of their knee pain, and they get the common answer from a doctor, well, if that hurts, then don't do that. Well, that is true advice and is good, but we have to put that in a context. And so some degree of discomfort is acceptable if we're making progress and we're making gains, as long as we're not setting ourselves back and leading to worse issues and worse progress long term. So if we're seeing a negative functional capacity, and we're doing less and we're being in more pain and we're seeing less gains, then we're probably doing too much, and we need to look at those activities and how can we change those activities to have less impact. So maybe if you've been walking and you're having more pain, we take a couple of days off walking, but maybe we do some yoga, or we get in the pool, or we do some stretching, because stretching by itself can have big impacts for our joints. Or we do some isometrics, so where we don't actually bend the joints, but we fire the muscles, we get blood flow to our muscles, or we do some cold therapy, or we do some heat therapy to those joints to allow for function and quality of life.
Thank you. What is the recovery time after a partial knee replacement?
So obviously all joint replacements have some ongoing recovery that I tell people can take up to about a year. The benefit, I think, for a partial knee replacement is a little bit quicker than a total knee replacement for it. So whereas I tell patients and total knee replacement takes about 3 to 4 months to sort of really get over the hump and really recover from it, still getting better up to about a year. A partial knee replacement, I tell people it can take about 4 to 6 weeks, maybe up to 8 weeks to get over that. That doesn't mean everyone takes that long. So I have some patients who by a week to 2 weeks are already driving or already back at things. I've had some who are on the even quicker recovery that by 2 days are driving, 2 weeks are chopping lumber, are back to their normal activities, off all assisted devices. But I would not tell patients that they're behind the curve if it takes them 6 to 8 weeks to get over a partial knee replacement.
Thank you. What happens when both knees are bone on bone and painful? So do you replace one at a time? And if you do, how do you choose which one to do first?
So common question I get, and a great question. So obviously when you have two joints that are painful and two joints that are arthritic, then it is a decision tree about which of those two you do them. I personally, in my practice, have gone away from doing bilateral knee replacements. I'm trained in it, I know how to do it, but I feel like that's a large impact on the patient. It puts you at a little bit of extra risks that I think we can avoid if we stagger those joint replacements. And so I will commonly do one and then do the second one about 4 weeks later. Allows for your blood stores to come back up, so you're lower risk of getting a blood transfusion. You have less pain at the antecedent surgery because you're not having two knees you have to recover from. Also means you have a quote unquote good knee to offload your replaced knee in the recovery. So it allows you to get up and get moving a little bit quicker versus if you had both replaced. They've done data shows that you're at a higher risk of needing to be discharged to a rehab facility or a skilled nursing facility, which is not my goal. My goal is to get you at home and allow you to recover at home, which has better functional recovery, has lower depression rates, lower delirium rates, and an overall better outcome. And so by giving you that 4 weeks, you get that first knee replacement recovered enough to where that can then be your good knee to recover on as you go through that next knee. Does prolong your recovery by about 4 weeks. But I think in the overall quality of recovery, the longevity of your recovery, I would rather you be able to focus on one knee at a time and to lead to an overall better outcome for you in the long term for it. And then which one do you choose first? Sometimes we choose to do the right one first so that one can be recovering and then allow for earlier return to driving as you're recovering from the left one. Other times, my general recommendation is whichever is the most painful one is the one that you should move forward with first.
Thank you. If you had a traditional total knee replacement, could you have a robotic revision of that knee replacement later on?
So great question. So at the moment, some doctors are using robotics for helping with some aspects of revision, mainly for conversion from partial knee replacements to total knee replacements. They are not as advantageous in the current platforms and the current software we have to be used for the complex revisions. But for some of the more simple partial knee replacements to total knee replacements, it can be used. But in general, it is not used for complex revisions.
Thank you. So you've given information about hips and knees, but do the same types of treatments like the activity modification, the injections, the anti-inflammatories, and so on, are those similar treatments used for back arthritis and for arthritis in other joints?
So there is some crossover in a lot of these aspects. Obviously, the injections, not all applicable, but exercise, weight loss, the medications, exercise in general does show benefit in all different arthritic joints. So yes, there is a lot of crossover in them. And so yes, those can help in all those other aspects too.
Thank you. How do you tell the difference between arthritis pain and other pain? Like if you have a meniscal tear in your knee, how do you tell the difference between arthritis pain and tear from the meniscus?
Yeah. So obviously that is where somewhat the art of medicine comes in. Obviously, there are some different tests and things that can help give us further knowledge of it. But then there's also the aspect that some of these things are associated. There's not just one or the other. You have arthritis, and because you have arthritis, your joint space is narrowed down. As your joint space narrows down, it puts more pressure on the meniscus, putting you at more risk to then getting a meniscus tear. So you actually have both. You have arthritis and you have a meniscus tear. For most of my arthritic knees, I tell them, almost I can guarantee you have a meniscus tear. And that is something that gets addressed if we have to go forward with surgery that we then remove that damaged meniscus at the same time we address the arthritis, so that you address both at the same time. And just because you have a meniscus tear doesn't mean we have to go in and address the meniscus to manage the arthritis like we do with the medicines, with the injections, with the therapy, with the bracing. Those still can be the treatments even when we are dealing with the arthritis if we have a meniscus tear.
Thank you. Can a patient who has a joint replacement have an MRI after the replacement?
So yes, all of our joint replacements are fixed enough to the bone that they're not at a risk for being pulled away from the bone with an MRI. It doesn't cause worsening pain with an MRI. So if you have to have that for your back or your head or other parts of your body, your shoulder, perfectly fine. And there's sometimes we actually will even order MRIs of the hip or of the knee after having one of those. We have special MRIs that try to cancel out the artifact or the scatter that happens from the metal of a knee replacement or a joint replacement. And so, yes, we even use them around the knee replacements or joint replacements.
Thank you. Does lifting weights help with joint mobility?
So lifting weights or doing weighted exercises helps build muscle strength and can sometimes lead to greater mobility if in doing that it pushes you through a motion to stretch out some tissues and stretch out the capsule. I don't view weight training as much as my functional mobility aspect. So joint mobility is done usually through stretching and yoga and things like that. And obviously they can work together, but I don't view them necessarily as by lifting weights, you will get better joint mobility. But by lifting weights, you may get strength that helps take down some of your pain, which may allow you to feel more mobile, feel that you have better mobility of your joint, and lead to better quality of life.
Thank you. That is all the questions that we have time for today. If you would like to make an appointment with Dr. Robertson, please head to OrthoVirginia.com. Dr. Robertson, would you like to close?
Everyone, thank you so much for tuning in for this. I hope it was informative. I'm sorry if you had other questions that we weren't able to address. We will try to address as many as we can offline. And then obviously I'm happy to see anyone in person to go over any questions or other concerns you have about your joints or other arthritic questions about staying active and those things. Because obviously in the end, our goal at OrthoVirginia is to increase your quality of life through keeping you active and minimizing your pain. And so any way we can help with that, please let us know with that. Thank you so much, and y'all have a wonderful rest of the day.